I'll try to be as brief as possible and not try to bore you a lot. As we all know, the role of radiotherapy is decreasing day by day in the management of gastric malignancies. So I'll try to be as crisp as possible so that people are not bored. Okay, so first of all, I'd like to thank my colleague, Dr. Samir. Dr. Manish is my friend from Indore, Dr. Viraj, and my colleague, Dr. Vega, for helping me with this presentation. We all know surgery is the mainstay of treatment for gastric malignancies, but it does require pre-op, either a pre-op or a post-op treatment, as only surgery is not enough, and the death rates are around 50%, which were quite high earlier. And in the last 20 years, we have seen we are doing something new things, and the results are getting better, but still not a very promising sight. We all know that we have been shifting to neoadjuvant setting. My talk is on the adjuvant role of RT in stomach, but let me just start with the neoadjuvant setting. And if you talk about GI malignancies, because today is a topic of GI, we know that we have moved from adjuvant to neoadjuvant in most of the sites of GI, starting with esophagus, gastroesophageal junctions, rectum, or a locally advanced borderline resectable pancreas, where these are the conditions where we give preoperative radiotherapy with chemotherapy followed by surgery. And in stomach, we do a perioperative treatment in the form of chemotherapy mostly, and in some selected cases we use radiotherapy also, either in the pre-op or the post-op setting. So why do we need NSCT or NSCT-RT? Because we want to get a R0 resection and a good local regional control as well as the distant control. And to improve that, we have been shifting to neoadjuvant chemotherapy or a neoadjuvant chemoradiation. And at the same time, we have to make sure that the patients tolerate the treatment well, so that we can have a better outcomes for this patient. Now, if you talk about GE junction tumors or gastric tumors, all the medical oncologists would agree that this was a trial, which changed the guidelines. FLOT. In the FLOT 4, 44% of the patients were gastric cancers. And here, we have started giving perioperative chemotherapy. Means you give chemotherapy before the surgery and you give it afterwards. And you saw the result. You saw the result that giving the FLOT, the results improved significantly. The p-value was statistically significant compared to ECF. The median overall survival was 35 months, which changed to 50 months, and R0 resection with FLOT came to around 85%. But the compliance was a bit issue. The Indian patient did not tolerate it very well. So people are using modified FLOT for a selected group of patients. And when you talk about the trials which are going on for the esophagus or the stomach or the GE junction tumors, these are a few trials which I found, and I'll just focus on the gastric ones. You see the Top Gear or a Critics 2 or a PREACT. These all trials, you can see they are comparing the CT versus followed by surgery followed by CT versus chemo followed by chemoradiation followed by surgery followed by chemo. Similarly, here it is CT followed by surgery versus CT followed by CT-RT followed by surgery versus chemoradiation followed by surgery. And PREACT, it is chemo, surgery, chemoradiation, surgery, chemo. So a lot of trials are going on for the role of radiation in stomach and GE junction tumors preoperatively. So we don't find too much of studies nowadays for adjuvant radiotherapy for stomach tumors. But now, as my topic is for the adjuvant, let me go into adjuvant. Now, this was a trial which set the ball rolling. The INT0116 McDonald's trial. It was published in NEGM 2001, where for R0 resected gastric adenocarcinoma, they were randomized to receive either 5FU based chemotherapy followed by chemoradiation followed by further 2 cycles of chemotherapy or observation. And here, if you see the results with the chemoradiotherapy arm was better than the surgery arm. But here the problem was, this was an earlier thing. This was published in 2001. So we are talking about patients taken in the 90s, where the D2 resection was quite less, 10%. And right now my surgical colleagues are so expert, they usually go for a D2 resection. But in that era, the majority of the patients were in the D0 or a D1 resection. So maybe that was one of the reasons patient had a very good response to chemoradiotherapy afterwards compared to chemotherapy alone. Now extending this further, this was again the continuation of the INT0116. In JCO 2012, this was published that there are different things. But if you see the D level, for a D0 and D1, it was better to go for an adjuvant chemoradiation compared to a D2 resection. And the interstellar variant of the histology of an interstellar type of gastric carcinomas did comparatively well compared to the diffuse type in this study. And if I can show you another one, if you compare this, if there is a D1 resection, and if you see surgery, there is a very high chance of local recurrence. Whereas if you add chemoradiation, the chances of recurrence are quite less. But if it is a D2 resection, it is almost similar. And if you see the survival, again, not too much of a difference, but yeah, chemoradiation was a bit better than the surgery alone. But whereas in the D2 resection, it was almost equal. Again, I found this study from Italy where they showed no improvement in overall survival or a disease-free survival even after adding chemotherapy or a chemoradiation in a D1 or a D2 resection. But this was a very small study. Now, this was an interesting study. This was an artist study which was published in GCO in 2015. It was a phase 3 trial comparing the adjuvant chemotherapy with capecitabine and cisplatin versus concurrent chemoradiotherapy in gastric cancers. And in this study, what was found, this was very interesting. If you compare both the arms, the survival was not too much of a difference. The p-value was 0.09. But in one particular area, when the nodes were positive, adding adjuvant chemoradiotherapy did better than adding only chemotherapy in node positive. Whereas in a node negative, there was no much difference in both the arms. So artist study showed that for a node positive, adding chemoradiotherapy was better than adding chemotherapy alone. Now, again, this is another study, artist 2, ESCO 2009, in which there were 900 patients with a D2 resection. Stage 2 to 3, lymph node positive, were stratified, and they are randomized to receive adjuvant chemotherapy with S1 for 1 year, or you take adjuvant chemotherapy with S1 and oxaliplatin for 6 months, versus adjuvant chemoradiotherapy, where you give 2 cycles of SOX followed by S1 plus radiotherapy, and the further 4 cycles of SOX. And the primary endpoint was disease-free survival. And if you see the outcome, the disease-free survival, the DFS was almost equal for both the group, means the chemotherapy, SOX or the SOX plus radiotherapy, they were both the similar ones. But you compare it with the S1, these two were quite better. So DFS was better, around 78 to 73% at 3 years for a chemoradiation arm or a chemo arm, compared to 64% for a S1 arm. Again, to subgroup, if you see it in a subgroup, if you compare the S1 versus the chemo RT or chemo, it was definitely better. But if you compare the chemo RT versus chemo alone, there was no statistically significant difference. It was a 0.4 p-value. So that this trial showed that there was no advantage of adding adjuvant radiotherapy for a D2 resection patients. Again, another study of critics, which was in Lancet 2018, they had randomized patients to receive 3 cycles of neoadjuvant chemotherapy, followed by surgery, followed by either 3 cycles of chemotherapy, or you receive adjuvant chemoradiotherapy. And in this critic study also, there was no benefit of adjuvant radiotherapy. If you see the forest plot, not significant difference between both the arms. And you see here, chemotherapy alone group was a bit better than a chemoradiotherapy group, maybe because of the chemo used along with chemoradiotherapy was a bit less intense compared to only chemotherapy arm. But this all studies were with conventional radiotherapies. The older studies were with conventional radiotherapy. Now, in the recent era of IMRT and ICRT, IGRT, and the recent era, by that I mean like last 15 to 20 years, where we have started using IMRT, we can deliver the dose more conformally, sparing the normal tissues. So even in a D1, D2 resection, if you add IMRT, they were better than the only conventional radiotherapy. So this was a study of a 68 patient, again a very small number for a D1, D2 resected patients. They added the chemoradiotherapy again with the trial like INT 0116, but with the IMRT. In the original INT 0116, it was 3D conformal radiotherapy, and in this study, it was a IMRT. Again, the course was exactly the same, and here they found the 3-year disease-free survival was significantly better in the chemoradiotherapy group compared to the only chemotherapy group, which was 56% versus 29%, and overall survival was again better, 68 versus 44%. This is again a very interesting thing. It was published in Journal of Cancer in 2019. How do the patient of stomach fail? They fail either loco-regionally, or they have a peritoneal metastasis, or they have a distant failure. If you see, you are not only worried about the distant failure. Here it was a patient of 1161 patients, where 29% had a distant failure, which we are definitely worried about. A 24.5 had a peritoneal, but a 22% had a loco-regional failure also. So there is definitely a role of local treatment as far as the management of gastric cancers is concerned. And adding the radiotherapy, you prevent a local failure. And with the newer techniques, you do a very conformal treatment, spare the normal tissues so you can deliver a proper dose which is required, and spare the normal tissues, which was maybe lacking in the previous days where you could not give proper dosage. The routine dose what we give for gastric carcinoma is around 45 to 50.4 gray adjuvantly with a 1.8 gray per fraction, so which comes to around 5 to 5.5 weeks of treatment. And if there is a R1 resection, we add a boost to that particular area. We may go up to 54 gray or 59.4 gray. And these are the areas where we avoid radiotherapy too. So this was something which was missing in the 3D conformal era, but which we can now do it very well with the IMRTs. So if you talk about adjuvant radiotherapy, the trials have shown that the intestine type of gastric carcinoma do a bit better with adjuvant radiotherapy. RT study showed that a positive rate of lymph nodes involvement was independent prognostic factor, and the patients who had node positive, they did better with chemoradiation. And there are other studies also which show that the N ratio, if they have more than 25% of the node positive, they do better, 55% compared to 28% if the nodes are less number of nodes are positive. Now to sum this up, I'll just show you the NCCN guidelines of 2021 and 2022. It is exactly the same. If you see here, what we do, so majority of our patient falls into this category. So we usually have a patient in our clinic which is CT2 or higher with any kind of nodes, and they're usually fit patients. In this scenario, we go for a perioperative chemotherapy. That is a preferred choice. So this is what is proven now, that we go for a perioperative chemotherapy. In the category 2B, you can go for a preoperative chemoradiation for a selected group of patients. Again, it has to be decided into the clinic, in a joint clinic. Or if the patients are medically unfit or medically fit but unresectable, you go for a chemoradiation. In a non-surgical, you can go for a palliative treatment. So surgery definitely is the main treatment. But nowadays, we have a role of perioperative chemotherapy, which is a category 1 for gastric malignancies. And if the patient has not received perioperative chemotherapy, say suppose the patient was of a clinical T2 or a T1, and we directly went for a surgery, and if it was a R0 resection, you observe if it's a T1. If it's a T2, you can observe, or you can go for a chemoradiation, the chemo followed by chemoradiation followed by adjuvant chemo for a selected group of patients. But if it is a T3 beyond tumor and node positive, if it's a D2 resection, which nowadays all the surgeons do, you don't do anything. You only add chemotherapy, no radiotherapy required. But if it is less than D2, if it's a D0 or a D1 resection, you go for a 5FU based chemotherapy, followed by chemoradiotherapy, followed by further chemotherapy. So the role of radiotherapy is very limited nowadays. For R1, R2, definitely you go for a chemoradiation for those patients. And if you are given preoperative chemotherapy and this patient has a R0 resection, you observe or you give adjuvant chemo. So again, no role of radiotherapy, even if there are nodes positive for a patient who have received preoperative chemotherapy. But yes, for R1 or R2 resection, you have to give adjuvant chemoradiotherapy with a 5FU based chemotherapy. So which are the possible candidates for adjuvant radiotherapy? You do it, if there is an inadequate lymph node resection, if it's a D1 or a D0 resection, intestinal type of gastric cancers, a T3 or a T4 disease, a patient having positive nodes or a high nodal ratio. These are the indications for adjuvant radiotherapy. But absolutely radiotherapy indications are a patient who has gone for a less than D2 resection, or a patient who has a more than R0 resection, maybe a R1 or a R2 resection. These are the absolute indication for adjuvant radiotherapy. Otherwise, our role has been limited in stomach malignancies. So I'll conclude my talk here, and I'm ready to take any questions if there are any questions.